Are you okay? Yes. Okay, so now I'll hand over to Nuhu to start and put up his slides.
Thanks so much. Can you?
And could I ask everyone else to mute as well? Sometimes we get a lot of rattling during presentation. Besides Nuhu, of course.
So can you see my screen? Juliet?
Yep, yeah, we can see your screen.
Okay, thank you. Thank you everyone for your presence here and for allowing me to actually present. And thanks, Jason, for a nice introduction of the team and also from myself. And as you know, as you can see that the title, I'm going to talk about the hospital sanitation system and assessing the health risk through the system modeling system approach in Bangladeshi hospitals. So the major structure of my presentation will be like introduction and overview, then literature review, method, and then expected outcomes. So in the introduction, as you know, hospitals in low and middle income countries remain the epicenter for emerging infection diseases and epidemics. And studies found that high concentration of hazardous chemical, microorganisms, and pharmaceuticals discharged from the hospital wastewater very frequently. In this diagram, you can see that hospital discharge in high-income countries usually go through the dedicated wastewater treatment plan and then discharge to the environment. But in the low and middle income countries, the hospital wastewater usually discharged directly to the drain, or actually with minimal treatment, and people usually got infected. And interestingly, these people actually go and going back to the hospital and seek for treatment. And this circle actually continues with this hospital wastewater and hospital infection. So my literature review will consist of two sections. One is hospital sanitation system, and then modeling fecal pathogen flow in health risk assessment. So in the hospital sanitation system, I will discuss about the sanitation latrine coverage and their quality according to JMP and WHO criteria. Difference between these high income and low income communities, healthcare facilities, infrastructure, and wastewater management, and disease burden, particularly from low and middle income countries, and overall management. And for the system modeling approach, we'll discuss about the QMR approach, and then how the fecal pathogen actually contributing the hospital wastewater and the interlinked diseases happening to this, who actually exposed to this environment. So let's start with the literature review of hospital sanitation system. So WASH in healthcare facilities usually display 5 parameters such as water, sanitation, hygiene, waste management, and environmental cleaning for the hospitals. And in this literature review, I will focusing on wastewater, sanitation, and waste management only, because although I am going to talk about the wastewater only, but these 3 are very closely interrelated to each other. And also I will talk about the global scenario initially, then with the low and middle income countries situation, and narrowed down to the Bangladeshi situation. So let's talk about the water a little bit, because volume of water generated from the hospital is closely linked with the wastewater generation in the hospital. So I will discuss in the later part of this slide. So on an average, there is like 40 to 60 liters of water generated from each hospital per patients. And for infectious disease or for surgical cases, it's about 100 to 400 liters. But global data is still missing for most of the cases, and limited geographical data are available, geographical distributed data are available globally. And the water used for hospital in different purposes is also limited. Like it's only few developed countries has some data, and also some data is available on India and subcontinent that how much volume of water is actually used for what type of. So this segregation is also important to understand for effective treatment. So before I jump into the wastewater management, let's understand what JMP actually service ladder for actually sanitation for healthcare facilities. And they have like usually 4 parameters with improve, basic, limited, and no service. So improve, when they say improve sanitation facilities, usually it is a contextual and there is lack of information on that. So basic sanitation ladder they have defined as improved sanitation facilities that are usable for and at least 1 dedicated facility for hospital staff, sex-separated ministerial hygiene facilities, and also with a disabled person. And limited service actually usually follow that at least 1 improved sanitation facility is available, but not all requirements for the basic service. And no service mean whether there is non-functional latrine or like hanging latrine, or that is not performing well, or sometimes or also there is no latrine as well in the healthcare facilities. And interestingly, only 37% of the hospitals in low and middle income country have met the basic sanitation services. Most of them are actually like limited service, and global data on like overall sanitation facilities and later is also not adequate. So now let's talk about the sanitation facilities in healthcare system. So improve and basic sanitation service is not easy to actually achieve, especially in low and middle income countries. Improve and functionality depends on many factors. For example, if you talk about the availability of the latrine or sanitation facilities for hospitals, we only consider the like number of beds and number of admitted patients. But in the picture, you can see that there are lots of patients actually. There are lots of caregivers actually every time, and also like which are not considered while designing this, and also like functionality of the toilet and like meeting the basic and improved sanitation is not actually standalone thing. So you have to like manage the both functional and also like JMP defined basic criteria. So latrine may be functional, but that not may be clean. So for the improvement of the like for usability, so both of these parameters are important. And another important thing which is really missing in the global data is like latrine user ratio. So maybe high income country, which is maybe there is some lack of less number of family caregivers and less number of patient flow in the hospital. But majority in the low and middle income countries, in recent study, I have found that the latrine and user ratio is about 1:12 to 1:16 in government hospitals, which is really difficult to challenge. So when you talk about sanitation facilities, these are actually basic things we have to consider to actually while I talk about these sanitation facilities. So now let's talk about the wastewater production. As I discussed earlier in the slide, that wastewater production is really correlated with the water generation in the hospital, but exact amount and volume of water is really difficult to like measure in the low income community, because there is no way that we can regulate and we can register the water in the low and middle income countries. Studies found that hospitals in high income countries have consume more water and produce more wastewater compared to low and middle income countries. In the right side of the graph, you can see the data is available in most of the high income country in the right side of the table, but in the left side of the table, you can see the only few hospital has in low and middle income country has this information. So while you while we want to actually develop any wastewater treatment plan, then it is important so that we can have this clear understanding that how much wastewater is generated from which service of the hospital. And at the same time that segregation of the water and like source separation is also important. And we know that lack of source segregation increase the volume of the wastewater and make the treatment very complex as well expensive. In the picture, you can see that most of the wastewater generated is black and gray water. So gray water might not need very sophisticated treatment and may be released whether without treatment or only for after chlorination. But black water that contains mostly like pathogens, microorganisms, and that can be actually also managed by conventional treatment like activated sludge procedure or like wetland can be actually used. But for the specific discharge that contain mainly like hazardous chemicals, drugs, so these actually may need more attention, although the volume is also very small. So when these three actually combine together, so treatment process actually very difficult to actually achieve. So that needs to actually consider, and which is also like missing in the recent literature. So also there is a huge gap in like understanding of hospital wastewater discharge mechanism for both high and low income countries. So as I discussed earlier, the hospital wastewater mainly discharged through the dedicated sewer network in the high income country, and hospitals and community sewage treatment plant actually treat together. And they usually use like advanced treatment technology like membrane bioreactor, moving membrane bioreactor, and so other different stages of wastewater treatment. And but for the low-income countries, there are a lack of like everything is going directly to the lake and also the environment, and people can get actually come with this contaminants. And mostly the low and middle income country, they use constructed wetland or like activated sludge process, not that membrane bioreactor and other sophisticated treatment options are also limited. In my recent research in hospitals in Dhaka, we have found that there is no hospital wastewater treatment in Dhaka hospitals, in government hospitals. Only that hospitals wastewater passes through the anaerobic biofuel reactor, but those are also not actually functional in most of the cases. And wastewater discharge parameter is also not consistent throughout the like different agencies and different countries. For example, if you can see that total suspended solid parameters according to US EPA is less than 30, but for other countries like India and China, that is actually 0 to 40 to less than 600. So there is a like inconsistency between the different parameters and how, because there are thousands of parameters here needs to be considered if you want to say these wastewater is clean. So that's why it is really challenging for the low-income country to which parameter they will actually adopt and follow. So this needs to be actually also resolved in the future research. So let's bring a little bit highlight about the hospital wastewater management in Dhaka, Bangladesh. And no previous and ongoing project we have found to treat the hospital wastewater. And in almost all hospitals in Dhaka city, there are the hazardous chemicals and hazardous wastewater directly go to the the environment. Only Japan International Cooperation Agency, along with the Bangladesh government, that city corporation work for hospital waste management. But most of the waste management is the solid waste management. There is no liquid waste management strategy for, there is a strategy, but there is no like action is taking on by the Bangladeshi government and hospital authorities. So global burden is also we is not sure that what the percentage of hospital effluent actually contributing the disease. So as I earlier mentioned that hospitals effluent actually merge with the community, and community people get sick. So in the right side of the picture, you can see the children are eating in front of the in the drain, and feces is visible over there. So this is actually a very common scenario in Dhaka, and there are very large hospitals beside this community while we started working in the Mirpur areas. So to have some better understanding, so we have set up some research question and objectives. So we want to explore the current hospital sanitation facilities and wastewater management in Dhaka city, and also like feasibility of modeling fecal pathogen flows from hospitals in neighboring communities and their health risks in urban Bangladesh. So our specific objectives are to explore the hospital sanitation system, water use, wastewater management and treatment strategy, latrine user ratio, and in the government hospitals, and develop and apply and validate the system modeling approach to inform the hospital sanitation infrastructure and management decision making. And the final specific objective is to identify critical gaps in the evidence base required to model pathogen flows and related health risks in urban environment of the Dhaka. So I will talk about the methodology in two sections. One is on hospital infrastructure data collection, and then we'll go to the modeling section. So we will conduct this study in government hospital, and you can see in the graph the hospitals are actually spread out throughout the Dhaka city, and we will conduct initially the cross-sectional study with the mixed method approach, and later then these information will be fit in the model for like exposure assessment. And the study will be like about 2 years project with like 4 to 5 months data collection. And we'll do the DEX review first of all with the systematic review and baseline data collection. So I will discuss in the later slides. So the selection of the hospitals. So in the DGH approved hospital, Director General Health Service approved hospital, there are actually 22 hospitals, and from these 22 hospitals, we have there are like 3 categories of hospital, like general hospital, medical college, and specialized hospital. So these general hospitals also divided in 2 geographical areas, like Dhaka North City Corporation and Dhaka South City Corporation, which is DNCC and DSCC. So we will try to actually collect information or like select at least 1 hospital from each geographical areas. And in the bottom box, you can see that finally we will select about 10 hospitals, and because there will be like few categories within these 10 hospitals. One is like year constructed. So some hospitals are constructed before 2000 and some hospitals are constructed after 2000. So we will compare the sanitation facilities with that parameters, like geographical variation, whether there is any variation of the installation in Dhaka South City Corporation and North City Corporation, and also like size of the hospitals, whether the facilities, sanitation facilities actually differ with the size of the beds and size of the hospitals as well. So let's discuss a little bit about the overall data collection approach. So in the method section, we will actually first of all, we will start with the literature review, and as I earlier mentioned, the systematic review and also some other report review. First, especially the JMP and WHO guideline will be reviewed very carefully to understand the current hospital wastewater scenario and waste management facilities in the hospitals. And also from the literature, we will know that pathogen prevalence of the catchment area and how it is actually quantified, and also the endemic diseases around the globe related to this exposure. And then we will actually review also within the hospital records to understand the patient's caregiver and number of toilets and users, so that we can estimate the volume of the use. And a key informant interview with hospital cleaners then ward master. Ward master is usually who actually manage the sanitation system and the meeting with the directors as well to understand the policy and funding source, how they manage it, and also the community leaders to understand how people get exposed to this hospital wastewater adjacent to this neighborhood. And structure observation for hospitals and communities to explore the children and adults, how they come into the contacts, and latrine functionality. We'll do the structure observation of each selected hospitals, and the drainage quality and wastewater options, management options. And also we'll measure the water and wastewater volume. We will use usually, like in latest study, we have used some tools to actually validate, and also like we have some methodology to explore the drainage, because drainage are not the formal drainage. Most of the time it's made of earth and not well structured. So we have some other ways to actually manage this volume. So now let's talk about the data analysis plan, and we will do the descriptive analysis and mean and standard deviation with interquartile event with the frequency of difference parameters. So we'll do a Poisson regression analysis for the prevalence ratio and to compare the old versus newly constructed hospital, high versus low users ratio. So we will do that analysis, and frequency of hospital that provide basic, limited, and unimproved service will be also like categorized according to the like WHO standard and JLP standard. We will also do the qualitative data analysis. For example, like after recording the data analysis, we'll transcribe that. And after transcription, we'll translate and code them with a different thematic approach. And after we have coding them, we will do a thematic analysis and report the results. We usually like do both like quantitative and qualitative reporting together to understand the overall scenario. So let's talk a little bit about the like modeling part, and just going a little bit overview of the modeling that this is a powerful tool to actually explain the mechanism linking environmental factors and infectious diseases. And system modeling approach is also like important to examine the examining and predicting the context-specific health impacts. And many studies use like system modeling approach to analyze and understand the complex environmental and pathogenic cause-effect system. But most of the studies have been conducted in high-income countries rather than low-income countries. So, and we didn't find any system modeling approach has been implemented in hospital facilities to understand the exposure and how people get infected. And we will follow the recent paper published by Tim Foster on the urban Bangladesh system modeling. So this system modeling will involve three parts actually: model development, baseline data collection, and secondary data collection on enteric diseases. And this will be the like overview of system modeling. That the model development usually I will talk in this slide, because rest of the baseline data collection and secondary data from the enteric disease and pathogen exposure will be already discussed earlier. So for the model development, we will use the fate transport model and also like exposure and risk assessment. So for exposure and risk assessment, we'll use the quantitative microbial risk assessment, that is QMRA. And for hazard identification, we will use the recently published literature by Mami Chinyusi from Virginia University. They have done a wonderful work in Bangladesh about like exploring the enteric pathogen and the causes of the enteric diseases. So we will use that like information or pathogen for our user feed our model, and then we will actually do this exposure assessment from the household survey infrastructure assessment. And we will do we have a recent study on Sanipath with Emory University, and we have estimated the amount of children actually and adults actually get contact with these environmental exposures like drain and soil and other So we have the data and we can use that as well. So final model will actually use like a different type of exposure and also like information. And this will be actually like number of toilet users from the hospitals in certain time period, then volume of water use for the toilets, or volume of water use, wastewater generated from the hospital, then pathogen shedding with the wastewater, and these will actually then pathogen concentration graph, and this will follow like ingestion dose and how much the children or the adults of the neighboring community of the hospital actually ingest the dose, and then actually we will probability of the infection of that particular person. So we will also estimate the actually DALI of that of these actually pathogen and exposure from these people. So we will use, like previously we have already like published I will follow the two publication from Freya Mail and of the team Foster to model development. So I'm still learning because I'm not an expert on this modeling. So I have done a lot of work in understanding the exposure from environment, but I will, through my PhD, I will do my analysis and I will learn from the modeling system from my supervisor and the team. So the expected outcomes of my study will be like availability and functionality of the hospital sanitation facilities in Dhaka city, how many latrines of the Dhaka city hospitals will adopt, or which category of the JMP they have actually for percentage of WHO categories hospitals and latrines in the Dhaka city, and understand the latrine users and ratio for the future development of the hospitals and number of facilities required for the government. And the fecal sludge management strategy will be actually explored from this strategy, and will be the future direction for what should be the strategy of the treatment option and other things. And also like sanitation improvement needs, whether like what type of treatment plan, what type of drainage of the hospitals and just a neighborhood needs to be installed through the modeling will be approved. So we will also get ethical consideration, considering Bangladesh is one of the high risk zone for this type of research. So we will obtain research ethical clearance from both the Human Research Ethics Committee and also like IRB board from ICTDRB. So written informed consent will be taken from all the participants, and all information will be kept secret and anonymous while presenting the data. And we will only use this information for research purpose, not we will leak for any other purposes. So let's talk a little bit about the timeline. As I mentioned earlier, that it was a 2 years project from the presentation and from the preparation of the proposal to the manuscript writing or thesis writing. So you can see in the middle of the graph about the data collection. It is about like 5 months data collection and then analysis and then report writing. So we need some approvals from Director General Health. So we have kept some time over there, and so that's important. So from our recent experience, we have found that government is also very much interested in this type of project. So we will also work together with the Bangladesh government to improve the healthcare facilities sanitation system. And finally, I would like to highlight one important thing, that future collaboration, that we have submitted grants on this on wastewater treatment technologies. We still actually we're waiting. So we will be also not only like UTS or will do the independently, but we will collaborate with the UTS engineers and IT and BUETS, which is one of the leading engineers in Bangladesh, Engineering Institute Bangladesh, along with Bangladesh government. We also have some good collaboration with Korean company who agreed to actually support us for innovation like delivering the innovative wastewater treatment plan for the future projects. So that's it from my side. So thank you for your patience hearing.
Thank you. Thank you, Nuhu. That was a great presentation. I might just ask you to take it down so we can see the group of people that are online. And there's lots of claps there I'm now seeing. So now's the time to go to questions to the broader audience. So, and give Nuhu a bit of a rest. It was a good presentation, so thank you. Are there any questions from the broader audience at this point? There was a lot of information in there, and valuable information. Any questions? Sometimes takes a while. Simon, you've got your hand up. Yeah. I confused it for a clap then for a second.
No worries. Thanks, Nuhu. That was really great to see what you've been working on, and I really enjoyed learning about that stuff I hadn't thought about before. I heard a lot about, I suppose my big takeaway from it is I heard a lot about how hospital management might change as a result of your PhD, but I was really interested in some of the specific risks that you might explore coming out of hospitals that might be different from a general wastewater flows, and specifically what some of those risks might be and the significance of them. And possibly there's links you could make to other types of industrial wastewaters or something as well. I don't know. I just love to hear you elaborate a little bit more on that side of things.
Okay, Simon, thank you very much for your question. I think specific risk from the hospital is actually important to measure, because as I mentioned in my like slide, that there is no information on what type of actually pathogen release from the hospital. In recent study, in community-based study, actually, we have explored that there are high concentration and high frequency of pathogen like Giardia, pathogenic E. coli, Vibrio cholera. They are present in the community drain. So since there is a close link with the hospital and the community drain in low and middle income countries, so there is a possibility of that. So but the problem is, for exposure assessment, if you want to quantify anything, it is very expensive because of like exploring the pathogens or the chemicals is really expensive. So we have that plan, but like we are also like exploring. For this study, we plan to actually do some lab work, but we found that it will be really challenging to budget will not be managed. So that's why we are planning for like secondary data for this PhD. But yes, you are right. Like we have some future plan with, like, if you get some funding, we will definitely go with that.
Okay. Thanks.
Jess, thank you, Simon. Jess.
Hi, Nuhu. It was so good to hear your presentation. You made me a little bit homesick. It's good, in a wonderful way. I could have 1,000 questions, but I'll ask just one around seasonal variation. And variation in water use within hospitals. I know it varies a lot in communities, and so wondering if that would be something to consider, and also if disease changes in that, and if that's been taken into account in your data collection plan.
Yeah, thanks, Jess. That's a really great question. And Juliet also asked me the same question earlier. And it's actually seasonal variation is really easy to collect, but the time of my PhD is I'm a little bit concerned. So that's why, like, I didn't actually concern this. That's why I planned for this cross-sectional type of things. But you are right. Like for within 5 months of data collection, I'm not sure if I will able to actually collect the seasonal variation. But I wish I could actually, like, if we get funding, definitely have that plan. Yeah.
Thank you for that, Nuhu. Are there any other questions from the broader audience? Okay, Tamara, yes.
Hi, thanks, Jason. Oh boy, Nuhu, you're trying to pack so much. So good luck, seriously, because it's amazing what you're trying to do. I was just wondering about the cultural side of things, because you're going to do observations and you're trying to also incorporate, I think I saw behavioral as well as part of your modeling. I know with these with the countries, because I come from Iraq, that this is very sensitive area. And I was wondering how you will be dealing with that, especially the female, the male aspects, and probably how to ask people about that because it's a very sensitive subject.
Sure, yeah, that's an important task. And as you know, I'm working in these settings from more than 10 years. So I have good understanding about the settings and also acceptability. So I'm really glad that, excuse me, so I work at ICDDRB, which is the international center, and we usually get the ethic approval from here while we actually work. So that's why I request Juliet that I will not only get the approval from UTS, but also from the ICDRB, so that I can say that we are also from ICDRB. So this will be a collaborative project with ICDRB. So that's how actually we want it. And for overcoming the stigma or the sensitive issues, we will definitely collect what we do for different type of, if we want to interview the women, we usually send the women who actually understand her. She will actually improve the rapport build up with her first of all, and then actually she collect. We put actually a lot of time in the field, not only just go and collect information, but also prioritize her. It could take actually an hour or more than that. And also we collect their phone number initially before going to their interview, and we actually request them to arrange their free time. And the poor people in the, particularly in the slum, mothers, they are really overwhelmed with their work. So arranging time for them is really challenging. So we considered this while taking information on interviews.
Okay. Other questions from the broader audience? We've got a few more minutes, so 2 or so more minutes. So one more question, or are we questioned out?
I'll ask another one.
Okay.
Since I have so many in the back of my mind, Nuhu will have to have a chat at some other time because I've got so many. But I'm curious about kind of governance. I don't know about the hospital situations in Dhaka. My experiences in other spaces, but and around governance and maintenance of toilets, and your pictures were spot on. I've definitely seen that. I know that that's the case. But is that maintenance? Are you concerned that they might clean things up if you come to do observations within hospitals? Is that a possible concern, or are there issues around making sure we get accurate kind of understandings of what the situation is? Because I know that can also happen.
Yeah, that's an important question. So I'm really lucky that I am able to actually join a lot of sanitation workshop with the government, and they invited ICDRB, and since I'm working in this sector since 2017 and more. So that's why government has revised their actually health wash in healthcare facility proposal, and they have set some parameters. And since Bangladesh is going to be a middle income country, so they have also some responsibility right now to actually improve this facility. But they don't have the information. So through this PhD project, so I will try to actually focusing on this population proportion, users latrine and users ratio. This is very crucial. So if the users ratio is not actually maintained, then how you will actually manage? And also they don't have any idea about hospital effluent. They are only discussing about the solid waste management. So all the wastewater management is related to hospital solid waste management. So that's why whenever I went to any forum with the government and the policymakers, then I raised this issue that not only the solid waste, but also the liquid waste and effluent is very important. So I plan in the next 2 years, if I get some funding through this university or other donor, then I will definitely go for policy implication of these findings, and definitely I will go for discussing with the higher official of the policymakers.
Okay. Thank you, Jeff, for that question. Any further questions? Yes, Simon. The last question for the group. Simon, you're on mute.
Here we go. I thought of something else just then as you were answering the questions. I'm intrigued about, it's kind of linked to the first question in some ways. I'm interested in the scale of your sampling of pathogens. So how far away from the hospital or you're planning to sample, or kind of the scope of your sampling. Have you got into that level of detail yet, or? Because I think that's really interesting in terms of how widespread the impact might be from the hospital wastewater.
So we didn't actually define the catchment yet. So definitely we need some like understanding. So this is also a new concept for us as well. So we have exposure in like community settings, but we don't have any understanding of how much, because all the wastewater going to all over the city, we understand that, and it's some 20% of this wastewater reaching the wastewater treatment plant, which is 15 kilometers away from the hospitals. So we are still like need to learn more about how can we actually decide the catchment number one. And about your sampling, if you consider about, if you want to know about the sampling of the wastewater or environmental sampling, so for this study, we are not actually doing that because we use the like secondary data.
Okay, so at this point, just given the time, and we've only got a restricted amount of time for the second half, so I'll thank everyone for coming, the broader audience for coming, and if everyone can congratulate Nuhu for his presentation, and then we'll now go to the assessment panel process, and if I can ask others to leave. And thank you for coming, but they've been great questions.
Thanks for supporting. Thanks, everyone.
Thank you. That's it. That's right. Everyone can now unmute if they want.
Yeah.
So,
thanks. Well done, Nuhu.
Yeah.
Thanks, Juliet.
Well done. And so we'll keep the recording going. There will be a part when we go to the closed panel where Nuhu and Juliet send you to a holding room for a while. We'll turn the recording off at that point, and then we'll put it back on after that for the final part. So at this point, we move into a discussion with the panel. And usually what we do is the panel has an opportunity to talk and ask questions, further questions, but also it's a chance for you to actually ask the panel questions as well. So it's not just one way, please don't think it is.
Okay.
So Susan, not to put you on the spot, and you can say you can go later. What we normally do is, because basically I'm sort of here as the chair and everything, and the supervisors are here. The supervisors have been talking to Nuhu for many, many years, for a year at least. And so usually the biggest insights come from you. So usually what we do is ask the independent panel, external panel member to ask the first set of questions. If you're happy to do that.
Sure, no problem.
Okay.
Well done, Nuhu. That was a really nice presentation. It was very clear and very interesting. So well done. Congratulations. I just wanted to ask you, first of all, from your experience and now thinking specifically about fecal pathogens, how do you anticipate that the waste stream from the hospital will be similar or different to what we might see from a residential setting?
Okay, thank you, Suzanne. I think this is a critical question, that some information is over there in the literature, particularly in some high-income countries. They have some estimated the amount, and there is some good amount of systematic reviews as well that actually estimate the volume. So they usually actually have, the literature actually usually have estimated the treatment efficacy, some treatment efficacy with effluent quality before and after with different parameters. Some estimated the chemicals, and some estimated the amount of pathogen actually explode, like discharge to the environment. But the dilution factors and others issues are really complex, like in the hospitals for low and middle income countries, the wastewater generation and the water generation in the hospital, volume of water is not clear. So that's why that is important, that before we understand the mechanism, how much pathogen actually coming to the community. So we have to understand the hospital environment first of all, and the generation and fluid. So once we understand the overall volume, then we actually understand the wastewater and what is the content with the wastewater from the hospital. And definitely there is some difference from the community versus hospital wastewater quality, because in my understanding from last couple of years, that I found that like only the fecal pathogens are more predominant in the community. But in the hospital, there will be drugs like antimicrobial resistant genes and antimicrobial resistant bacteria. These are most predominant, along with other like X-ray and other chemicals in the hospitals. Yeah, that's my thinking, Susan. I'm not sure if you have any like leading question, like follow-up question with that.
Well, so I didn't see it in the scope, but are you also planning to look at antimicrobial resistance in your modeling?
No, for this modeling, we will also focusing on the some pathogen that causing that idea. Yeah.
I thought it was very interesting, and I think that the data that you collect from the hospital itself will be really key in terms of the modeling, because it is, I can see it's going to be very context specific in terms of why the people are in the hospital, what illness they have will impact upon what happens to their fecal material, and also how that fecal material is cleaned and disposed of, whether they're able to use the latrine or whether they're being cared for by family member or a hospital staff.
Exactly.
So I can imagine that will be really interesting and new to look at what that means. I also wondered too about in a developed country, there would be very high usage of disinfectants for cleaning, and what that might look like in your setting and how that might impact pathogen concentrations. It may actually in the modeling reduce the pathogen numbers and possibly change the scenario that you're looking at. But I think that would be relevant, It's like what we talk about, in a hotel room, the cleanest place is probably the toilet. The worst thing is the remote control, so it's like, in a maybe hospital wastewater there's so much else going on there that the enteric pathogens that there's different considerations. So I found that interesting.
It sounds right, Susan. I'm not sure I'd be willing to test the hypothesis.
I think Chuck Gerver's published on it. I also want to ask you talked about doing a systematic review to obtain your secondary data to inform, your pathogen numbers. So just talk to me about what you're planning to do with that systematic review and what you're thinking the sort of scope and parameters of that review might be.
Yeah, thanks. I think we have already done and like work on that systematic review and finalize the keywords as well. So we actually try to understand the hospital wastewater treatment technology and their efficacy for low and middle income countries. So there are some recent studies on like global wastewater management, hospital wastewater management and treatment technology, but there is no data on hospital wastewater management in low and middle income countries. So, and for my experience in last couple of months, actually, I reviewed some of the literatures and I found that like hospitals in low and middle income countries has only depending on the septic tank and ABRs. Still, they are depending on the septic tanks and ABR. And they consider these as a community wastewater actually. So that's why similar implemented. There are some in India and China as well, but those are not scalable because of maybe the funding or hospital funding. So we will actually primarily focusing on the hospital wastewater treatment technology and their efficacy in low and middle countries.
So the questions will be what treatment processes are in place globally or specifically in low middle income countries?
Yeah.
And how well do they perform? Will you be looking specifically at how they perform for pathogens and microbes or other factors as well?
I'm not sure there will be much data on that, like pathogen and microbes. As I mentioned, in China and India, there are some literatures I found, but no studies have conducted in African region because, you know, they have less different type of geographical settings over there. And mostly like these tropical areas in India, Bangladesh, and these subcontinent is dealing with the diarrhea and other cases very severely. And in Africa, they are dealing with different type of other infectious diseases. So I will focusing on all the low and middle income countries, but on the data on the pathogens or chemicals exposure with that low and middle income countries, I'm not sure like how much data is over there. So we will explore that actually. And while working on that keywords, like we initially think about 10 years, last 10 years, but when we found that there is very limited number of literature we are getting, then we actually going to from like more than 20 years of information we are trying to gather in from this systematic review.
Okay. And do you have a library team helping you with that, or is this part that you're doing this yourself?
Yeah, I'm taking like help from UTS library and also like ICT, they have also good research at library.
Yeah, interesting. Great. Was there other people asked those questions? Oh, I just wanted to ask you about the quantitative microbial risk assessment modeling, because obviously that's my expertise. How are you feeling about that at this point? And have you done any QMRA yet? Talk to me about that part of it and how you're feeling about embarking on that.
So yeah, I think I talked with Juliet, yes, like the last meeting as well, that I am just learning this QMRA, but I'm really lucky that I work with team in the ground while he was in Dhaka. So UTS has a great team on this modeling team. So yeah. I usually plan to actually go to UTS and actually after collecting data, I will learn this full modeling. But yeah, I know the basic concept of the QMRA, that how to collect the information and how to extract information from the particularly the frequency of frequency of pathogen exposure for different diseases, and then infectious dose on different pathogen, and what should be the exposure with that different. So since I work with Sanipath team as well from MOE University, and they are doing similar type of work, and I also published some papers on pathogen flows and wastewater discharge. So I understand, but I am still learning about this wastewater and modeling things, to be very, very honest. So yes. I really need to learn this, and this is my one of the priority work. From my office, where usually I work, and I'm on leave now, and we are also I'm implementing this system modeling approach to actually ICT as well, so that we have a good team to actually work in Dhaka continent, so that we can work in future as well.
Yes, excellent. So am I allowed to give a suggestion at this point?
Sure.
But my just suggestion in response to that is I was looking at your Gantt chart of tasks, and I saw that you were planning to do your data collection and then do your modeling afterwards. And I would just suggest, if you talk to Juliet and Tim maybe about the idea of setting up a simple model very soon, so that you are familiar with what inputs you're looking for your particular model, and what that's like to be putting it into a spreadsheet and doing the calculations, because I feel I think it will probably influence what data you go to collect when you go to the hospital and what you're looking for when you go out and do the the exposure assessment. And if you don't do the modeling till after you've done that, you might then think, oh gosh, I wish I had asked an extra question, or I wish I had done something slightly differently. So even though it's painful, I would suggest that you try and sit down and set up a model as soon and then come back to it later and refine it.
That's excellent suggestion. Yeah, I think I agree with you. Yeah, I'll do so. Yeah.
That's all for now.
Oh, thanks so much. I went through your profile, and I'm really impressed that you are the master of this QMRA thing. So I might need your help in the future as well. Yeah, thanks so much for your important suggestions. Yeah.
No problem.
Okay, I might just give Susan a bit of a rest there for a second. And Juliet, Tim, did you have any questions at this point? I mean, quite often what happens during these processes is something new completely comes up that hasn't come up during the discussions. Maybe not, or?
I guess I'll maybe ask one to do with, as you answered several of the questions, you talked about, I guess, the complexity of the wastewater flows, and even when you answered to Susan, it makes me wonder, for the hospital that is the focus for doing the modelling, just what level of detail you think we might need to get to around the black water flows, the grey water flows, any other flows, in order for it to actually be a realistic, just a realistic scenario that we're working with, and whether that's going to be feasible and possible.
Good question.
Did you catch all of that, Nuhu?
Oh, so feasibility. Okay, so one is Juliet, through this study, we'll definitely do number one, the feasibility study. There will be an infrastructural design which might be needed in the future to understand segregating the black or gray water, and from my understanding, it will not very much easy with the Bangladesh government hospitals, because they need to change the policy, and they have different wings. But good thing is, since last couple of projects we are doing directly with the Bangladesh government, so that's why they will be sensitized on this. And usually what happened, government usually do this responsibility by their own, not actually fall to any other research institute. So that is, I would not say this study will actually directly impact on this structural changes, understanding the complete scenario of wastewater management, but it will also it will at least show the overview of what needs to actually change in the future, and what should be the parameters we need to change in the hospital for the effective wastewater treatment in the hospital systems.
No, I think you're right, Nuhu. I think you missed a little bit the last part of my question. So when I used the word feasibility, what I was talking about was just the data collection process in the hospital, and how realistic is it for us to get a really good understanding of all the different water flows in different parts of the hospital and where it ends up, in terms of the grey water, the black water, or any other streams. Do we feel that that's going to be something that we can have empirical data on, so that we have a good idea of what's coming out of that hospital?
So for that information, from what I plan in the proposal, that first of all, we will actually estimate the water source, what number of water source actually coming to the hospitals. The hospitals have their own water source, and they also Dhaka, Wasa water source. So we have to understand and how many times they have refill that. So that's how we will estimate the amount of water into the hospital. So once we estimate the water into the hospital, and then it will be easier to actually how much water actually consumed. So it will depend on how many hospitals will actually cover this type of in-depth analysis of water use, but definitely not for all hospitals, I believe, because it will be challenging to our estimate. For example, laundry, kitchen, and other like operation theater water use is really challenging. So I'm not sure about the methodology. Like I will definitely explore whoever actually did this type of water quantification. I will definitely need some support from those people as well.
I have a question at this point. Nuhu, as you might know, my interest is at the intersection of health and planning and architecture. So what you're doing is quite interesting to me. And you know, the big challenges I always have is in this area, there's two groups of knowledge coming together. One is design, and hospitals are complex, one of the most complex facilities you can create. And it has operating theatres, it has different units which have different purposes. And then health fits into that. And you know, there's dedicated architects and planners and others who actually design, spend their whole life just focusing on the operating theatres. There's others that focus on the rehabilitation part of the hospital, and they all come together and eventually construct a hospital. So I suppose I'm going back a little bit to Juliet's point, and I'm just wondering, I mean, you've got a big scope, and I understand it sounds like there's a lot of information, there's a lot of opportunity in there, in that scope. But I'm just wondering, from my perspective, is there some way in which you could make sure that, how do I say it, you've sort of, as Susan is saying, you've almost structured out that scope at the beginning. And you know, you've thought about the hospital as a complex facility. There's inflows, outflows, as you say. But it is there, but when it goes through the middle, there's a whole heap of different spaces with different purposes, and some might have particular uses. And they will have different types of water flows through them and out of them. And they'll have different types of usages and chemicals, and as well as outflows from bodies. So I'm just wondering, is there a way of approaching all of that in a way that's sort of quite systematic? And I think you've got a lot of it there, but I think I'm building on something Juliet's saying, which is, if you were to come into a whole heap of information in different parts of that, how would you know which ones to focus on for a thesis, if that makes sense? Because it is big. Or is it you're going to be very systematic and just say inflows, outflows, and the hospital becomes a singular object in that, which is also one approach. So I'm just thinking about the complexity, and I think it's an incredibly important project, and it is one of those facilities which have the potential to have incredible impact on communities, especially which I'm understanding from what you're saying. Did you understand the question, Nuhu? Or you don't? Maybe it's not a question you can answer right now. Maybe it's one you can think about. But I'm thinking from the point of view of, as Susan said, there's an element of how do you measure risk and do
Jason,
the risk assessment.
I think I can supplement some of your question maybe. So there are actually some good hospitals as well, like newly built, very much engineering architected hospital. So for example, if I can say like Kurmitola General Hospital, Neuroscience Hospital in Dhaka city. So these two hospitals has very well furnished. They have good sanitation facilities, and they have well organized. They have wash committees. So that's why like we choose those two hospitals as well as our understanding that what is the actually mechanism of like water use, wastewater treatment. So we will also we have also selected hospitals that are like not very well designed, that wastewater mapping is not there. So we will then actually come up with the analysis plan that whether like improved hospital and modern technologies can be actually different. What is the difference and gap between these? Whether these are similar or they are dissimilar. So based on that analysis, we can recommend whether like old structure, can we actually make this like long-term plan to actually change the structure and improve this so that we can save the environment. So that's why, like, if we can collect some information on improve latrine, improve hospital versus lower not improve hospitals, then we can actually show the government. So this is the happening. And from these sanitation approach and from the modeling, we can found that this amount of people of your country actually affected. Then actually people actually want to know the health impact. Only they want to hear that how much intervention will be impact the improvement of the health. So if we can show a little bit on this, hopefully government will be actually understanding. And we can saw in our previous research that when I do this pathogen flow modeling on the wastewater, then people are getting sensitized that definitely wastewater is not a very, like, septic tank or ABR is not a good solution for this community because of overpopulation, because of lack of management. So that can be actually complemented in the hospital similar way in the future. It will take time, definitely, Jason. Okay. Juliet, you can add anything if you want. Yeah.
Yeah, no, that's all good, Nuhu. Yeah. Tim?
Yeah, I might chime in with a couple of questions. I mean, an interesting point about the design, Jason, because I think, I can't even imagine how difficult it would be to design a hospital. But I guess one thing about what you're proposing, Nuhu, is that, or in terms of what you're going to focus on, one is looking at sort of an inward-looking thing in terms of how do the sanitation facilities serve the people in the hospital. And I presume that's kind of, when people are designing hospitals, they design it with the patients in mind, and obviously the clinical teams, but keeping people as healthy as they can. But I guess you're also looking out external to the community. What are the potential negative externalities of that design to the broader community, which is is an interesting one. But when you mentioned hospitals and architecture, Jason, I thought of Darwin Hospital, which is apparently a mirror image of Canberra Hospital and therefore has snow eaves. But anyway, my question for you, Nuhu, is just, we've discussed it at our last meeting, just around, the potential to choose a range of pathogens, because, if you don't have a sampling, a part of the work, you have a little bit more flexibility to choose different pathogens. And so I guess my first question is, have you kind of got a short list of ones you'd like to focus on? And secondly, one of the things we've discussed is the potential value of getting empirical data on the etiology or the pathogens that are causing the cases of diarrhea of patients going into certain hospitals. So I guess a linked question is how, based on your discussions and your knowledge of what's going on, say, at ICDRB and the sort of surveillance they have in place, how feasible do you think it is to get that sort of information for specific hospitals?
You're on mute.
Nuhu, you're on mute.
Sorry. So yeah, this is very valid question, team. And as we discussed that there are certain surveillance system is going on in different Dhaka hospitals and also outside of the Dhaka hospitals. So the problem is though some of them are private and small hospitals, and they didn't actually not necessarily actually representing all hospitals in Dhaka city. And also ICDRB hospital surveillance is only dealing with the enteric diseases all over the country, only diarrhea and cholera patients they deal. And that will also not representing the other settings, but definitely we can understand the number of patient and number of exposure and how much pathogens are over there. For the literature review team, I have went through a number of recent studies about the which pathogens are prevalent in Bangladesh for causing the disease, enteric disease. So I have that information. I need to go back to check them again and need to prioritize that first of all, that with the Bangladeshi context. And since in 2021, there are some actually recent paper published from ICDRB and other health sector. And I will also focusing on these subcontinents so that we can actually do some good information. Yeah.
Great, thanks, Nuhu.
Okay. Did anyone else have any other questions at this point?
Well, I get, a question that actually jumps off the way Tim described what Nuhu's going to do, which makes me think, are there any further steps forward one could do on the inside health bit? So the way you expressed it, Tim, was, how do the sanitation facilities inside a hospital look after the health of the people that are kind of accessing and using them? That's a slightly different framing to how we've talked about it so far. We've talked about it much more as just knowing about the infrastructure and etc., and more in terms of the monitoring. But it is an interesting question as to think about: are people getting, potentially in the hospitals, are people getting sick from the poor sanitation in the hospital? And is that something that we want to make sure that we've got our eye to, if the overall topic and thing that holds your whole thesis together is about health risk of sanitation within hospitals? So it's more a comment than a question, but it would be a slightly different focus, I think, to the first half of the research if one were to take more of a health lens to it.
I mean, an interesting side point to that, I guess, as well, is, when the JMP team, when those indicators were formulated, that they're all about the sanitation facilities in the hospital, nothing about what happens to the wastewater after it leaves. And whether that was the primary rationale for whoever came up with those indicators, was it thinking about, the health and well-being of the people in the hospital as opposed to those, outside in the community.
I'm thinking we're exhausted questions at this point. Nuhu, did you have any questions for the panel? You don't have to.
Not so, because I have enough today. I think I have lots of questions.
I can understand that. I can understand.
So I just one supplement I would like to suggest. This is a challenging project, I know, but I took this because I already have all the settings here. Like I have the field staff here. I have the settings. I know the community very well. So that's why I'm a bit confident that I can do this type of work, but it will be really challenging in the field when I enter into the hospitals. So that's why we have to start very as soon as possible to have the approvals and go to the rapid build up, so that we can collect in the next 6 months, we can complete this data collection. So that I can invest my time for the modeling and other paper writing analysis. So this is very time sensitive proposal, definitely.
Okay.
3-year PhDs always suddenly feel really short.
Yeah. Yeah. And it's only possible to do cross-sectional in PhDs, not longitudinal. So, okay, at this point, we'll move to the next part of the process. So the next part of the process is usually where actually,
Tim and I step out, don't we?
Yeah. So if you could try, can you send yourself?
Yeah.
Can you send you both to a room, and then we have a little bit of discussion, Susan, Nuhu, and I, just about the process to date. And then it'll probably take about 5 minutes usually.
Yeah, you can just call us.
Yep, sure.
Back,
yeah.
Actually, can you call me back if I put myself?
No, I don't think I can, because you're in control.
Yeah,
so.
Can I make you a co-host, and then you will be
able
to?
Yep, that would be absolutely fine.
All right, done. And I'm going to go join Tim. See you later.
See you in a minute. Okay. So, so the purpose of this session is just for Nuhu to have a bit of a discussion with people who are outside his supervisory team. Just to say, I just actually noticed that, wait there, which one stopped? If I press recording now, okay. Okay. So the response was more than happy with the arrangements as they are. So,
Jason is really nice, you know, he asked only like simple questions, not very critical one.
Right, well, as long as you were honest and felt comfortable.
yeah.
Yes.
Yeah. 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 And so now we go a little bit more
Next.
musical chairs.
Next
So,
reshuffle. So I'm going to put Nuhu in a breakout room.
yep.
Yeah.
And at the same time, I will just put the recording on pause again. So.
Yeah. All right. I've lost the button. Sorry.
Oh, okay. I
Closed
can find it.
caption
I've got it.
You got it? Can you let him back?
Yep, he's coming back in 29 seconds. It's always interesting because people either follow the 29 seconds or know to or decide to click the button.
So just on speaking to him, what we often do is just make one short comment each. Yep. So people happy to do that?
Yep.
Suspense.
Is it like a personality test? Can you go the full 30 seconds without clicking the button?
Some people are more. I think it's sort of like cultural as well for different people. Nuhu, are you?
Hey.
Welcome back. Hope that wasn't.
Thank you.
Too torturous being held in a prison cell for however long that was.
I was just thinking that why it's so long, taking so long.
Just to explain, we have to go through about 15 criteria.
All the criteria that you've seen.
And then you'll get all the suggestions and helpful hints. It's all suggestions and helpful hints.
Okay.
Back from the panel members. So that's why it takes. Maybe I should explain that earlier on. So
it's totally fine. Yeah.
The candidate isn't so stressed.
Okay, so Nuhu, we're very pleased to let you know that you've been assessed as satisfactory in this stage transition. So well done.
Thank you so much.
No, you did really well today. Yeah. You delivered a really clear presentation, and we think that there's a clear need for the research you're doing. You're clear about the directions you want to take. The main things that we've talked about in amongst the panel is the need to strengthen your grasp and focus on the modelling and QMRA part of the research, and to do that earlier rather than later. And that in general to make sure that the entire research scope is clarified, so that it's not over ambitious within the time frame. But I might just ask others if they want to add or elaborate any of those points for you.
Yeah, I'll just say that I think that you're doing really well. I was really interested and impressed by your progress and by what you're planning to do. I think it'll be a really important contribution and really valuable to a lot of people. So congratulations, and that's exciting. I think the QMRA will be very challenging. I think it will be, whatever you do will be a nice contribution, because I haven't seen anything done on that yet. And I think that it's an obvious spot. But it will be hard because you'll have to simplify it down, and Tim will be able to help you heaps with that, because he did that with the previous study. But I'm looking forward to seeing what you do with it. It'll be really good.
Thanks, Suzanne. Thanks so much.
Yeah, great stuff, Nuhu. Congratulations. Excellent presentation. You've done a really great job in pulling this all together, particularly given, changes of direction and so forth. And I think, obviously we all agree you've found a topic with huge potential in terms of the need for evidence in this area. And I guess, the modelling is going to be a challenging component, but it's really pleasing that it's a skill you're really enthusiastic about developing. And that's the main thing, because you've got to get up every morning for the next 2 years and think about this sort of stuff. So, having that appetite for really strengthening, your skills in this area is a really important part of that. So really looking forward to seeing how the next 2 years goes.
Because I was just going to say, I think building on all the positive comments that came before, I think it was a great presentation, a great topic. And I mean, personally, I'm really interested in the topic, not only because it's a great topic in itself. And I'm looking forward to the stage 2 to 3 to see actually what comes out of the research and how you make this. And that's probably what I could add is how you move from all these models, concepts, to actually the implementation, and how you make that shift in a way that is comfortable for you, that gives you that balance between your expertise in health and stretches you that little bit towards the modeling and allows you to actually create a juncture and fill a gap, which seems to be huge. You know, I think most people here, one of the comments that was coming up before is, why hasn't this area been addressed before? And so what I think, I mean, my point would just be along the way to be conscious of that transition from the frameworks and the models to the implementation, and being able to just continuously narrow things down as needed to get to that end point. And be comfortable about you've made the right decisions along the way. So for example, why choose certain pathogens and all that sort of thing? Are certain ones more important than others? Are certain waste types more important than others to look at? All those sort of things. I just wish you luck on this next part of your journey. It's probably the most exciting part of the journey in a way, actually going out and getting the material. I suppose the other point I'd say is just be aware of the complexity of going out into the field and making sure you have enough support in doing that before you step out into the field.
Sure. Yeah. Thanks, Jason. Thanks so much.
Okay.
Great. So, yeah, is there anything you want to add, Nuhu? But otherwise, I think we're pretty much.
Thanks. I think Jason for like chairing the session. It was really nice to I have the little introduction with you earlier. So I think this is a great opportunity that you learn my research, and also like Susan to actually come to my presentation and you know about me at this moment. So we will definitely knock you in the stage 2 and stage 3 period to actually share our thoughts. So be prepared on that, because this is how we actually developed the previous work. So we have shared our thought in the expert, and they have provided their comments. So yeah, I'm really happy with this session. It is, although this is very intense, but I really like the approach. Yeah.
I think
I appreciate all of your time. Yeah. And I, as say, that Juliet and team support, without their support, it will be really not possible to actually I'm sitting here and doing my PhD from Bangladesh. It will be really challenging. Yeah. I really acknowledge their support.
Yeah. So Nuhu, have you had any indication yet from the Australian government or UTS about when you might be able to come to Australia?
Yes, actually there is no travel restriction after 15. So I can board anytime. But what we have discussed with Tim and Juliet, that it's better I have finished my data collection and then I go to actually for 1.5 or 2 years.
Yep. I saw that in the report on progress.
Yeah.
Okay. Well, I'd just like also to thank Susan for her support during the session. It's great to have that outside view on a topic, because sometimes, things can evolve inside an institute with a particular viewpoint. So it's always good to have an alternate viewpoint.
Thanks, Jason. Pleasure. Thanks for including me. It's a real honor.
Okay. So Nuhu, congratulations.
Yeah. So Nuhu, we're going to try and write up the report pretty quickly before both Jason and I go on leave at the end of the week. So you'll have on paper, some of what's been discussed, hopefully in a clear way by the end of the week.
So on that note, Susan and Tim, what I'd say is once Juliet gets it out to you, what Juliet or I need to see is either some edits from you if you want to do edits on it, which is great. But if you're happy with it, you've got to actually send an email back to Juliet or me saying you're happy with it.
I can do that.
Yeah, okay. One of the two. Because sometimes that step doesn't occur.
It's just left hanging. Yeah.
We're left hanging. So
yeah.
Okay.
Okay.
No worries.
Thanks everyone.
All right. Yeah.
All right,
Thanks, everyone. Well done,
Thanks, Susan.
Nuhu.
Thanks, Nuhu. Thanks.
Bye.
Yeah.
Well deserved
Bye.
rest, Nuhu.
Bye.